you all are doing well. Today I'm going to talk about a little bit of psoriasis and eczema. So the first case, which one of the following is most commonly associated with psoriasis? Angular stomatitis, optic neuritis, scarring alopecia, response to chloroquine, or Koebner phenomenon. Now, psoriasis is the right answer will be Koebner phenomenon, because psoriasis is not associated with angular stomatitis or optic neuritis or scarring alopecia. And of course, chloroquine has been known to cause psoriasis in few cases. So the right answer will be Koebner phenomenon. Psoriasis is a chronic relapsing inflammatory disease, and it manifests as scaly, well-demarcated plaques with silvery scales. And diagnosis is usually clinical, and skin biopsy is rarely required for diagnosis. New lesions often appear at the site of injury or trauma, and this is known as Koebner phenomenon. And this is typically occurs in 1 to 2 weeks after the skin injury has taken place. There are other conditions where also you can see Koebner phenomenon, as in lichen planus, verruca vulgaris. These are also known to cause Koebner phenomenon. Psoriasis can be associated with anterior uveitis but not optic neuritis. Angular stomatitis means inflammation of the angle of the mouth, and it's commonly associated with candida infection. It can be associated with allergy, seborrheic dermatitis, vitamin D deficiency, and iron deficiency. And it is not commonly associated with psoriasis. Rather, psoriasis is known to be associated with geographic tongue. The scalp is often involved in psoriasis, especially in children and adults, but it can cause telogen effluvium due to stress or because of excessive itching. They can experience some amount of hair loss, but usually there is no scarring alopecia or there is no hair loss due to the disease itself. Up to 30% of patients with chronic plaque psoriasis may be affected with arthropathy. It can range from mild distal interphalangeal joint involvement to nail pitting to severe arthritis mutilans. While the exact cause of psoriasis is not known, but we know that it does have a genetic basis, and European populations are most commonly affected, and it's the middle age from 20 to 40 is the peak age. Males and females are equally affected. External factors like infection, psoriasis, medication can exacerbate. Some of the common medications that are associated with psoriasis are beta blockers, lithium, gold salts, and antimalarials, and also non-steroidal anti-inflammatory drugs can aggravate psoriasis. So now psoriasis has been associated with various other comorbidities, and it has been shown that if we don't control the inflammation of the psoriasis, the other comorbidities can actually worsen. It has been associated with metabolic syndrome like hypertension, dyslipidemia, in diabetes, obesity, and increased risk of cardiovascular disease. We also know psoriasis is associated with increased psychosocial burden. This patient becomes more depressed, they have suicidal tendency, there's more incidence of alcoholism, and psoriasis can be associated with inflammatory bowel disease, and there can be anterior uveitis, as I mentioned before. So the NICE guidelines regarding management of psoriasis says that we have to assess the disease severity and its impact on its quality of life and refer to appropriate specialists. And we need to check for psoriatic arthritis. We need to identify the comorbidities, and topical therapies, and general recommendations are mainly emollients, and then we have topical therapies in form of topical steroids, coal tar preparations, vitamin D ointments like calcipotrials. Then in addition, we can use phototherapy. It can be narrowband phototherapy. Also, we can use psoralen and UVA phototherapy. Systemic non-biological therapy includes methotrexate, azathioprine, cyclosporine, mycophenolate. And then we have the biological drugs like infliximab, etanercept, adalimumab, secukinumab, ustekinumab, ixekizumab. All these have been found helpful in treating psoriasis. Now, the next patient, 74-year-old gentleman, present to dermatology clinic for review. Had history of red facial rash and had suffered with venous eczema of both legs. He was treated for acne rosacea in the past. On examination, he has noted blue-gray discoloration of his both lower extremity. Which one of the following drugs is most likely responsible for his presentation? So they are already telling you the drug is the reason for this blue-gray discoloration. So is it ciprofloxacin, minocycline, tetracycline, doxycycline, or amiodarone? So minocycline is classically known to cause blue-gray discoloration. The gentleman has developed skin pigmentation and is blue-gray in color, and it's a treatment side effect of his acne rosacea. Tetracyclines are commonly used for rosacea, and long-time use of minocycline is particularly associated with blue-gray pigmentation of the skin in the lower legs and mucosal pigmentation. It is mostly because of a minocycline melanin complex which gets deposited and gives this color. And it's more common in elderly. Biopsy shows intercellular pigment in the dermis and subcutaneous tissue, and it stains positively for melanin and iron. If not extensive, hyperpigmentation may partially regress after minocycline is discontinued. If persists, Alexander laser therapy can be effective to treat this kind of pigmentation. Amiodarone can also cause blue-gray slate discoloration of the skin, typically on sun-exposed area. Therefore, expect the face to be affected, and also amiodarone is not treatment for rosacea. So definitely this won't be the correct answer. Hypersensitive to sun has been described with ciprofloxacin because their quinolones are photosensitive drugs, but discoloration is usually described here is blue-gray and over the legs. So definitely ciprofloxacin is not the answer. Oxytetracycline and doxycycline can lead to photosensitivity, but skin pigmentation seem to be specific to minocycline rather than any other drugs. As you can see in this picture, this blue-gray pigmentation over photo-exposed area, this is over the lower leg, and this is very classic with minocycline pigmentation. Also, if the acne patients are treated with minocycline, they can develop pigmentary changes on their acne scars. So the next patient, 21-year-old lady, presents to the emergency department with extensive erythematous rash that has appeared virtually overnight. She had no significant past medical history, and she states that she has suffered from streptococcal throat infection 3 to 4 weeks previously, for which she took 1-week course of oral antibiotics. On examination, she had multiple erythematous papules and plaques on her body and upper arms with superficial scaling. Her vital signs are normal on examination. So which one of the following is the most anticipated diagnosis? So this is a lady with extensive erythematous rash, which came up suddenly. The only significant history is the streptococcal throat infection. And she had antibiotic treatment. So is it lichen planus, gutted psoriasis, drug eruptions, pityriasis lichenoides, or pityriasis rosea? The correct answer will be gutted psoriasis. So lichen planus won't appear overnight, and it's not associated with streptococcal infection. Gutted psoriasis is the only condition where you can see the patient is having erythematous scaly rash, so probably psoriasis, which can be associated with streptococcal infection. Drug eruption, yes, you have to think of, but again, if you want to make these two association, streptococcal infection and rash, probably psoriasis becomes the most selected answer. Pityriasis lichenoides chronica again can present as scales, but it's not associated with any infection. And pityriasis rosea is usually quite innocuous. Again, you have a herald patch and then you get other lesions, inverted fir tree pattern, which is not in this case. So gutted psoriasis is characteristically said to occur 2 to 3 weeks after streptococcal infection. Multiple psoriatic plaques can appear over a short period of time. Palm soles are rarely affected. The plaques are mildly itchy, self-limiting, resolving after a few weeks. UVB radiation may accelerate plaque resolution in patients with extensive disease, and it has been associated with HLA type BW17, HLA-B13, and HLA-CW6. Drug eruption is unlikely with scaly papules and plaques. And again, Psoriasis rosea, as I said, it begins with Herald patch. Psoriasis lichenitis is a possible differential, but although acute disease, but occurs as papular rash, which again extends to form plaques. And the size of the lesion are much smaller. And mostly the trunk is affected. And of course, there's no history of any infection. Similar to Psoriasis rosea, lichen planus usually affects limited areas of the skin at onset. It doesn't flares in one go. So next patient, we have a 41-year-old lady with intensely itchy red scaling rash, which affects her scalp predominantly and is worse in spring and winter time, and is referred to dermatology clinic for a review. She also had a patch on her chest and around her cheek. On examination, severe scalp rash with crusting and scaling of skin. Investigations are almost within normal limits. Scalp biopsy shows hyperkeratosis, acanthosis, and focal spongiosis. So she states that she cares most about her scalp. Which one of the following is the most appropriate first-line treatment for this lady? Again, let's go back to the history. She had an intensely itchy, red scaling rash, and it's mostly on the scalp. Okay, and there's crusting and scaling. Usually with psoriasis, you don't get crusting. So she must be having something else. And there's hyperkeratosis, acanthosis, and focal spongiosis. This focal spongiosis actually gives this oozing and crusting. So which one of the following is the most appropriate first-line treatment? Is it tacrolimus, oral prednisolone, topical betamethasone, coal-tar shampoo, or ketoconazole shampoo? So most likely this lady is suffering from seborrheic dermatitis. So the correct answer will be ketoconazole shampoo. The lady had seborrheic dermatitis, which tends to affect the hair-bearing areas, and scalp is the worst site to be affected. It is thought that at least in part, the activity of the activated T cells may be enhanced by an increased reservoir of Malassezia yeast. As such, regular washing of hair with ketoconazole-based shampoo has been shown to reduce the severity of the condition. Topical steroids have been shown to hasten recovery, but may be associated with rebound effect and recurrence of the rash when they are withdrawn. Coal-tar shampoo and topical tacrolimus are alternate treatment, not the first-line treatment. Steatotic dermatitis typically presents in elderly with pruritic, xerotic, scaly rash over shins, but may occur over the back of the hands. Tar-based preparations are never used as they would worsen the condition. A 68-year-old gentleman attends to the clinic of the dermatologist with 3-month history of dry pruritic rash affecting upper back and shin. Which one of the following is the first-line treatment for this gentleman? So 68-year-old gentleman with 3-month history of dry pruritic rash, upper back, shin. First-line treatment, is it emollients, skin biopsy, avoidance of contact irritants, patch testing, or topical steroids? And it's a 3-month history. So he's suffering for quite some time, but it's not really bothering him. So the right answer will be A, or is the emollients. The gentleman is likely to have steatotic eczema, which is a more common problem and will improve with just plain emollients. Xerotic skin is common in elderly population, especially in the winter months due to dry heat from central heating. All other suggestions may be appropriate in patients resistant to first-line treatment. And if the emollients fail, then definitely we can use topical steroids. But first we have to replenish the dryness with emollients. A 47-year-old gentleman with atopic dermatitis attended emergency with acute generalized exacerbation of the disease. He was admitted to hospital, failed to improve with emollients, topical betamethasone 17 valerate, and oral antihistamine. Which one of the following is the most appropriate therapy? Cyclosporin, acitretin, amoxicillin, dapsone, colchicine. So, worsening of the atopic dermatitis, which has failed to improve with emollients, topical steroids, antihistamine. So, the gentleman will need some systemic treatment. Now, among the systemic treatment giving quick relief, cyclosporin is known to act best. Acitretin is not generally medicine of choice for atopic eczema. Amoxicillin, antibiotics can sometimes help in oozing or secondary infection, but it won't really cure the eczema. Dapsone, again, not the drug of choice, and colchicine is also not used for acute eczematous cases. Cyclosporin is a well-used drug in treatment of atopic dermatitis, and the dose is 2 to 5 milligram per kg body weight. The pathology of atopic dermatitis is complex, and it is due to T lymphocytes are involved, and it is known that it's because of increased production of cytokines, particularly IL-4, which causes the dermatitis, the inflammation and the dermatitis that we see in atopic dermatitis. Cyclosporin is a suppressor of T cells, and in that respect, it works very well with atopic dermatitis and psoriasis. The most common side effects are hypertension and renal toxicity. And these patients are seen monthly to have the blood pressure checked, serum urea and creatinine and electrolytes, especially magnesium, are checked regularly if the patients are on cyclosporin therapy. So cyclosporin is a calcineurin inhibitor. It inhibits translation of cytokines intercellularly. Side effect-wise, it can have CNS confusion, hallucination, can cause alopecia, gingival hyperplasia, hypertension, hyperlipidemia, GI intolerance, renal toxicity, mainly in form of nephrotoxicity. It usually causes afferent arteriolar vasoconstriction. Thereby, in due time, it increases the renal hypertension and cause renal damage. Cyclosporin can give rise to low magnesium level, high potassium, hyperuricemia. Skin-wise, they can have acne, hirsutism, and it can cause diabetes. So, if your patients are on cyclosporin, you have to be very aware, especially for hypertension and renal side effects. A 67-year-old lady presented to the emergency department with a generalized erythroderma 4 days duration. She had a prolonged history of psoriasis. Examination revealed her to be shivering but otherwise well. She was treated as an inpatient with emollients and attention to fluid replacement and temperature control, but no improvement was noted after 5 days of therapy. Which one of the following is the most appropriate next line management for this lady? Is it topical coal tar, dithanol, oral methotrexate, oral prednisolone, or oral hydroxychloroquine? So, generalized erythroderma of 4 days duration. She already had a prolonged history of psoriasis. So, she's shivering. That means her barrier function is damaged. That's why temperature control is becoming difficult. And she had already had a fluid replacement, temperature control, but she doesn't show any improvement with this. So she will need some systemic therapy. And of this systemic therapy, the most appropriate will be oral methotrexate. Erythroderma is an emergency as patients are susceptible to profound dehydration, infection, and hypothermia. And because their skin barrier is lost, that's why they develop this. There's a lot of loss of water. This temperature balance becomes difficult, giving to hypothermia, and of course, there's chance of infection. And sometimes they can lead to high output cardiac failure. Methotrexate would be the only correct treatment for someone with erythrodermic psoriasis, steroids are contraindicated in psoriasis. Always remember, if you give steroids and after you stop the steroids, they are susceptible to come up with this pustular psoriasis, which is again another severe condition. Hydroxychloroquine has little effect on psoriasis. Topical coat tar and ditronol can be used for chronic blast psoriasis, but not in case of erythroderma. And when the skin is more inflamed, topicals are not going to help the patient. So you need a systemic treatment. Methotrexate would be the drug of choice among these options. So whenever patients of erythroderma comes across, for all patients, it's appropriate to use wet dressing with mid-potency steroids. You should attend to the fluid tolerance and control edema. You have to rule out sepsis, rule out other causes of erythroderma, including PRP, Sézary syndrome, drug eruptions, and atopic eczema. Among the systemic therapy, first-line therapy, acitretin, biologics, infliximab, adalimumab, ustekinumab, cyclosporin also works wonder, and methotrexate. And among the second-line drug, again, acitretin, cyclosporin, TNF blocker, methotrexate, they can be used again as a second-line treatment. Here you can see extensive erythroderma, and the skin may crack and cause oozing. The whole barrier function is lost. Now, the next patient is, which one of the following statements regarding psoriasis is correct? Gutted psoriasis often arises after staphylococcal infection. Cyclosporin is ineffective for treatment of psoriasis. Twin studies have identified no genetic basis of psoriasis. T cells play a prominent role in pathogenesis of psoriasis. Diagnosis requires histological confirmation. So which one is correct? Does gutted psoriasis, does it arise from staphylococcal infection? No, it's streptococcal. Be very careful. Suppose you know that streptococcal infection causes gutted psoriasis and you don't check this is staphylococcal and not streptococcal, you might just take on this answer. So be very careful. This is a very tricky question. Cyclosporin is very effective in psoriasis. There is genetic basis for psoriasis. We all know that. And T cells does play a role in pathogenesis. And not always diagnosis requires histopathological confirmation. So the right answer will be D. Streptococcal infection is associated with precipitation and recurrence of gutted psoriasis, not staphylococcal. And cyclosporin is major inhibitor of T cell activation, and given that T cells are central to the role of pathogenesis of psoriasis, it is very effective for treatment. Genetic studies had led most experts to believe that psoriasis is the result of multiple genetic factors interacting with environmental stimuli. Genetic factors also seem to contribute to the clinical manifestation of the disease, for example, age of onset and the severity of the disease. Next patient, which one of the following statements regarding treatment of psoriasis is true? Etanercept is not effective in psoriatic arthritis. Vitamin D analogs are associated with cutaneous atrophy. Retinoids are most useful monotherapy in psoriatic patient. PUVA is ineffective. Infliximab is associated with tuberculosis. So which one is true? Etanercept is not effective in psoriatic arthritis is a wrong answer. It can help psoriatic arthritis. Vitamin D analogs are used to avoid steroid-induced atrophy, so they do not cause cutaneous atrophy. Retinoids as a monotherapy is not very useful in most of the patients. And PUVA can be effective in certain patients. Infliximab is associated with tuberculosis. This is the only correct answer because we all know biologics. When we use biologics, we actually alter the immune system. We are playing with the immune system and it can actually make the patient more prone to unusual infections. So we have to be very careful when we are using biologics, especially with infliximab. The most important adverse effect of infliximab is increased risk of infection, including sepsis and opportunistic infection. Patient with predisposed underlying conditions such as diabetes have more high risk of infection. Any severe infection develops with infliximab we should temporarily stop the biologic and antibiotics should be given. Tumor necrosis factors carry a warning of reactivation of tuberculosis, which is also called black box warning. And this warning advises prescribing physician to screen all patients for tuberculosis before initiation of therapy, to treat those with latent disease, and to monitor patients for signs and symptoms of tuberculosis throughout the treatment of infliximab. In a recent review of 130 cases, infliximab-associated tuberculosis reported to FDA, many cases occurred in patients with negative tuberculin test, but with risk of tuberculosis. Most cases occur shortly after initiating the treatment. Presentation may be disseminated or miliary. It might not be classical presentation, so you have to be very careful. A screening chest X-ray is essential, and testing for tuberculin sensitivity should be considered in all patients who are given infliximab for various reasons. Etanercept is again a recombinant tumor necrosis factor and receptor fusion protein, demonstrated considerable beneficial effects in psoriatic arthropathy in placebo-controlled double-blind studies. Part of the attraction of vitamin D analogs over steroids that it does not cause skin atrophy, whereas steroids do. Retinol is most effective in combination with UVB phototherapy, or as a monotherapy, it's not very effective. Psoralen and ultraviolet is effective therapy for psoriasis, but this has been related to increased risk of squamous cell carcinoma and possibly malignant melanoma. The next question, a 68-year-old gentleman at his emergency department with severe exacerbation of psoriasis. He has a history of long-standing psoriasis and heavy alcohol consumption. He was admitted and received topical therapy over a month of his admission. Serum gamma glutamyl transferase concentration has fallen from 390 to 145. He was seen in outpatient department a month after discharge, found that his psoriasis remained under control, but complained of generalized hair loss. Which of the following is most likely to cause the hair loss? Trichotillomania, thiamine deficiency, telogen effluvium, alopecia areata, or iron deficiency. So since he is an alcoholic, so trichotillomania is probably out. The most common diagnosis will be telogen effluvium, which is triggered by many factors, include treatment with pathological conditions with various medications. In above case, the gentleman was hospitalized for prolonged period, causing stress. Hence, this telogen effluvium will be the correct answer. Thiamine deficiency per se doesn't lead to hair loss. There are many other symptoms of thiamine deficiency. Alopecia areata usually presents with well-defined areas of hair loss. And iron deficiency can contribute, but it won't be, it will be more subtle hair loss over a period of time. Thiamine deficiency is more related to rapid weight loss and less related to hair loss. Alopecia areata is an autoimmune disease, and as I said, it damages the hair follicles, so we have a plain bald areas of hair loss, and it can affect any part of the body. And I'm sure all of you have come across alopecia areata, and it's a very sorry, I lost the thing. It's a very shiny, bald, well-defined coin-shaped lesion, alopecia areata. Here they say there's diffuse hair loss. So alopecia areata is not the right choice. And iron deficiency can cause shading, but it will cause over a period of time. Here we already have a history of hospitalization. So the right answer will be telogen effluvium. The next question, which one of the following statements regarding psoriasis is true? Gutted psoriasis is the most common form of disease. 1% patients can have associated arthropathy. Prevalence of psoriasis in UK is 10%. psoriatic arthropathy precedes cutaneous lesion in roughly 20% of the patients. Psoriasis is more common at lower geographical altitudes. Among all these statements, the most right answer will be psoriatic arthropathy precedes cutaneous lesions in roughly 20% of the cases. The prevalence of psoriasis is 0.5 to 4.6%. For reasons which may be explained by the filtering of UV light, psoriasis is more common in higher altitude. The common form psoriasis is plaque psoriasis, 80% cases, gutted psoriasis 10%, erythrogenic 3%, pustular 3%. So, the plaque psoriasis is the most common variety. And studies report that 5 to 42% of prevalence of psoriatic arthropathy in patients of cutaneous psoriasis. And arthropathy precedes cutaneous lesion in 20% of these cases. Cutaneous lesion precedes joint disease in 60 to 70% cases. And they occur simultaneously in 10 to 20% of patients. The next question, 72-year-old gentleman presents to dermatology clinic with generalized erythema and pustule formation. He has history of psoriasis, recently been treated with oral prednisolone for asthma. Which one of the following most appropriate next course of management? So, generalized erythema and pustule formation in a known patients of psoriasis. So, the patient has landed up with pustular psoriasis because he has been treated with oral steroids for asthma. So, which will be the next appropriate course? Is it skin biopsy, treatment with erythromycin, psoriasis PUVA, patch testing, or admission to hospital? Of course, admission to hospital because pustular psoriasis is an emergency and it can again cause exfoliation of the whole skin. So, in his admission for supportive treatment, IV fluids and antibiotics and appropriate treatment of pustular psoriasis. Next question, 21-year-old lady with poorly controlled eczema attends emergency department complaining symptoms have deteriorated significantly. She had crops of painful itchy vesicles affecting in particular patches of eczema in both cubital fossa and back of her leg. She also had low-grade fever. She had temperature 100.1 degree Fahrenheit, blood pressure 100/72. She had obvious convoluting eczema, which is poorly controlled, covered with extensive crops of vesicles, which have been deroofed to form ulcers. Blood investigations revealed mildly elevated CRP. Rest of the investigations are normal. So, which one of the following most appropriate management for her condition? Or acyclovir, flucloxacillin, high-dose topical steroids, varicella zoster immunoglobulin, or oral steroids? The answer will be A, acyclovir. The reason being, if you go to the crops of painful itchy vesicles affecting the patches of eczema, and she had a low-grade fever, and that she has deroofed lesion vesicles with ulceration, and she has raised CRP. So, the most likely she is having eczema herpeticum or Kaposi's varicilliform eruption. So, the right answer will be acyclovir. This lady's vesicular rash, most likely due to herpes simplex infection, superadded over eczema rash, a condition known as eczema herpeticum or Kaposi's varicilliform eruption. Patients with poorly controlled eczema are at increased risk of developing this disseminated disease. And it's a dermatological emergency. And if you initiate acyclovir immediately, it works like a magic. Parenteral treatment is usually required if the patient is unable to take tablets or if they are deteriorating in spite of oral medication. The superficial infection is not bacterial. Flucloxacillin is not of any value. Varicella zoster immunoglobulin is not of value because the rash is related to herpes simplex infection, and further use of steroids can aggravate viral infection. Although sometimes topical steroids can be used in areas where atopic rash has worsened. The next question, 14-year-old boy with severe atopic dermatitis who have been well controlled with topical treatment. despite good compliance. His dermatologist decided to start him on treatment with oral cyclosporin. Which one of the following parameters needs to be regularly monitored while he is on cyclosporin? So 14-year-old boy, his bone age, height, pubertal staging, blood pressure or blood glucose level. Cyclosporin usually does not affect bone age, height or pubertal staging. It can affect the blood pressure, we know, and blood glucose it can affect, but more importantly, blood pressure. So the correct answer will be D, blood pressure. Hypertension is most commonly associated with cyclosporin treatment. It thought that the associated with systemic and renal vasoconstriction, and it disturbs the circadian regulation. Vasodilators such as prostacyclin and nitric oxide are suppressed, whereas vasoconstrictors including endothelin are increased. And because of afferent arterial constriction, glomerular filtration is reduced and sodium retention is increased. Target organ damage has been shown to occur more rapidly due to these changes, including intracranial hemorrhages, left ventricular hypertrophy, microangiopathic hemolysis. In order to avoid such target organ damage, blood pressure must be closely monitored so that a treatment can be initiated rapidly and we can stop the cyclosporin. While cyclosporin can mildly impair glucose tolerance, this is much less common than hypertension. And as I said, bone age, height, and pubertal staging are not associated or affected with cyclosporin therapy. Thank you very much.